in various places. I'm Sarah Fineberg, and I am a psychiatrist and also a clinical researcher in the psychiatry department at Yale. And I do continue to see patients, and also I run clinical research studies. And I'm going to talk today about some recent pilot work we've done on ketamine treatment of borderline personality disorder. And I know that many of you are probably well acquainted with BPD. In my clinical setting, this is something that people are not very well acquainted with. So I thought, just to make sure that we're all talking about the same thing, I would, let me make sure that these slides will advance. I would just start out by talking about BPD a little bit. And then I hope that we can talk about the pilot results and that people will jump in. Feel free to ask questions. And then that we'll talk a little bit about putting in this in the context of some of the other reports that there have been about ketamine for BPD. So just to sort of remind people that the term borderline comes from an old psychoanalytic definition that places personality organization on a spectrum from people who are having variable traits, but those that are not so extreme, able to get along in the domains of work and self-definition and self-other distinction, and are resilient to stress overall, compared to people who, by the old definitions, would be having a psychotic level of organization and having more extremity in all of those domains. And people with borderline personality disorder often encounter a lot of invalidation and stigma because they appear at many times to be able to function at a very high level, and then find that they're less resilient to stress and can have periodic and extended disruptions of function and theory of mind that can be quite painful and ongoing. I think the 4-domain definition of BPD is an easy one to grapple with. So I like to think about BPD in this way, where borderline personality disorder contains symptoms in the affective domain. In particular, Mark Zimmerman has found that the most effective one-question screener for BPD is about mood lability. This is about 90% sensitive for BPD. If you say no to this, there remains only about a 1 in 10 chance that you still have BPD, although it's only about 30% specific. But so asking people, does your mood change from minute to minute or hour to hour throughout the day, can help you really find people who have BPD who would be worth further assessment of chronic mood disruptions, emptiness, impulsivity across a number of domains. Let me see if I have the mouse here. There we go. Including, importantly, some we sometimes forget, like eating and financial dealings. Disruptions under stress in perceptual domains that can look in the moment just like symptoms of a psychotic disorder. And prominently problems in the interpersonal domain that can drive the rest of the symptoms. So when someone has a strong conflict arising in a relationship, this can worsen the affective, impulsive, and cognitive symptoms. I like to take a moment whenever I talk about BPD to remind people how distressing and serious the situation is. Mary Lisa Johnson, who's a beautiful memoirist with BPD who writes about her own experience, says that BPD is like bleeding out. And for me, this evokes both the confusions interpersonally about where I stop and the person next to me starts, our colors are bleeding together. But it also evokes the very serious situation of bleeding out and bleeding to death. And it's a good reminder that the likelihood of dying by suicide in BPD is 50-fold that of the rest of the population. So just to quickly remind you, BPD is frequent. Somewhere around 1 to 2% of the general population has it, a lot more in most psychiatric settings around the world. Although it's more diagnosed in women, it's equally prevalent probably across genders, quite heritable, although these data are based on a small number of twin studies. And importantly, something we didn't know 25 years ago is that if we follow the trajectory of people's symptom status, the number of people out of this was a cohort of 300 people from McLean Hospital starting 25 years ago, that the trajectory of remission increases rapidly, and half of people who are diagnosed today should be in remission 5 years from now, and 10 years from now, almost no one is still meeting criteria for the disorder. However, if we think about recovery, and we set a definition of recovery as being people who have at least one emotionally sustaining relationship outside of their family and full-time work or school, you see that there's a big gap here between those that have remitted, no longer meeting 5 of 9 DSM criteria, and those that have gone on to having a really sustaining and recovered life in red. And this is the driving force for us doing better in our treatment of people with BPD. Although people's symptoms remit, they may not be getting back to a full life. So, and just quickly, I'll say the neural data are still quite unclear in BPD, but we do know that subjective and neural signals suggest that people with BPD experience rejection much more easily and with more experiences of factual inclusion than other people. That people with BPD are biased toward reading other people's faces as negative. And interestingly, others are biased toward reading the faces of people with BPD as more negative than is factually there. And the amygdala is hyperactive, partly probably due to inadequate prefrontal signals. So just that is the whirlwind reminder of what we're talking about here in terms of borderline personality disorder. So when I started this work several years ago, I was concerned about this. The number of ketamine providers in the United States was skyrocketing. And these ketamine clinics were being staffed by a number of different kinds of providers. We know that borderline personality disorder is underassessed and underdiagnosed even by psychiatrists. So the idea that anesthesiologists and family medicine doctors would be providing ketamine based on their assessment of whether somebody had treatment-resistant depression as a best formulation for their problem seemed concerning to me. And also there was increasing evidence of a lot of unusual dosing regimens and dosing routes, and some people were using even 6-fold the tested doses. I heard of someone who was compounding ketamine cream and rubbing it on patients' feet. All kinds of things were going on. And so it was sort of becoming a Wild West, as many of you know, in terms of ketamine treatment. And, so I was really concerned because, we know that people with ketamine are people with borderline personality disorder, also ketamine maybe, are at very high risk of having a course that's impacted by their alliance with their doctor, by their experiences of strong reactivity to placebo, and that treatment withdrawal, as can happen in a short course of treatment that ends, can be a high-risk situation for people with BPD. So I thought that it was going to be important to do a trial specifically focused on people who have borderline personality disorder, and that was the driving goal of this study. So we phone screened a lot of people, and we randomized ultimately 22. And so this is really a small study. That's an important caveat here. 12 people in our study got midazolam. We used standard doses at the time, still standard doses for IV treatment. So 0.5 mg per kg over 40 minutes of ketamine, or 0.04 mg per kg over 40 minutes of midazolam, delivered in a double-blinded fashion. We gave people 1 dose each. And so of the 22 people who participated in the study, slightly more of them got midazolam than ketamine. People were similar in age. On average, people were in their mid-30s in age. The study was predominantly female, but matched between the two groups. The study was predominantly people who identify as white, and most people had a sort of education into a year or two of college, so beyond high school. In terms of the clinical characteristics of the sample, both on the counts of people who met criteria for major depression and the scores, a lot of people met criteria for depression, and that depression was moderate. People had moderate, not severe BPD, and they also had moderate difficulties with social functioning. So this was an outpatient sample, people who were not acutely at risk, but who had significant BPD symptoms and wanted to feel better. Everyone was treatment seeking. So the first question that I was hearing from patients and potential participants was, am I gonna have real problems? This is a drug that promotes dissociation, and dissociation is frequent in my disorder, and I'm concerned that I'll have a terrible time, or I'm concerned that I'll get stuck dissociated and that it won't get better. So the first thing that we reported on in our paper is the intensity and the longevity of dissociation across the experience. So these data are about the during infusion experience, and we looked more frequently and in a more detailed way than most ketamine studies have done. So it's hard for me to compare these data to, for example, other depression or bipolar disorder studies, because most people don't look this many times. But we did measure the full CADS and the BPRS at 0 minutes, 20, 40, and 80 minutes. And we found that although the ketamine group did have a stronger intensity of dissociation, here's something odd, which is that the full dose of the drug was given to this time point at 40 minutes. So we are curious about why the most intense dissociation happened at the time of the half dose. We don't have a good explanation for this, although I have some ideas and I imagine you do too. We did not find a relationship in either group between the extent of dissociation and depression, which argues against the experience of dissociation triggering a placebo response or being responsible for a placebo response. We split our ketamine group into those who did have a history of dissociation, which again, this is a small number, it's like 5 people in each group, and those who did not. And we found that history of dissociation those people had a stronger peak of dissociation, but that everyone came back to baseline by 40 minutes after the time that the infusion stopped. And that was true also for the positive symptoms on the brief psychiatric rating scale. So now let me show you what happened over time. So we followed people pretty closely for a month after a single dose. And remarkably, a single dose of ketamine or midazolam led to significant symptom reduction that endured at least 2 weeks, maybe out to a month. Really, we don't see a return all the way to baseline level of symptoms for suicidality or depression. There's a suggestion here of greater reduction in the ketamine group than the midazolam group, but really people with BPD had a reduction in symptoms from being in this study where they received a single dose of drug. And, you know, we don't have a control for being in the study and not receiving a dose of drug, which I think is unfortunate and important here. Because of our study design here, at each of these time points, the participants met with my research assistants who were trained to be supportive for 2 to 3 hours. And so that the additional intervention here was an empathic conversation about their scores on the MADRS scale or their scores on the suicide rating scales. And we were concerned that people would drop out of the study. And so we held on to them kind of closely. I'll note though that the trajectories from participant to participant were quite variable. You can see here the ketamine participants in black, individual by individual trajectories, and the midazolam participants in the dashed lines. And so, you know, for example, like this participant here did receive ketamine, and I'll say this participant did not like the ketamine. She said that it was an uncomfortable experience and would not have liked to do it again. And she had this sort of bouncing course here. This participant here, remarkably, was very committed to a sober lifestyle. He had not himself had a substance use disorder, but there was one in his family that was quite severe. And he said when he was receiving the infusion, he became very upset that he felt high. And he said, I don't want to feel high. This is not part of my life. I don't want to do this again. And then the next day he called me, and before his appointment even, and he said, I just want to get something straight between us. I feel better than I've felt since I was in my 20s, 30 years ago. And I definitely want to do this again if possible. And he actually continued on to receive 6 months of clinical ketamine at our center, and he's doing beautifully. So, the people, it's kind of interesting that the different kinds of courses. Some people didn't have much suicidality, although this same person did have a lot of depression, and that got better. So that's kind of interesting too. To me, the most important result we had in this study is this one, that when we look at the trajectory of social problems, that we see a rapid reduction in social problems from baseline to the first time we checked at 2 weeks here, that was maintained at a month later, and a slower downward trajectory in the midazolam group. And we saw that in the ketamine, but not midazolam group, that there was a linear relationship between the extent of change in depression and the extent of change in social problems, such that improvement in depression predicted improvement in social problems in the ketamine group. So I think this is exciting because it gets back to this question that we have about trying to improve people's lives. Of interest, everyone's BPD symptoms got better. There was no between group difference at all. Probably there's a floor effect there, but we were interested to see that being in the study, receiving midazolam was as effective as receiving ketamine, but both groups had a significant change. So I wanted to just make note of some other groups who have published in this area over the last couple of years. There have been several case studies. I will highlight two. There's another that I think misunderstands appropriate approaches to treatment. But in one case report, and I'm sorry, I missed the reference here. One case report that came out in the last couple of years reports on a 27-year-old young mother who was self-harming and very depressed, and received a series of ketamine treatments together with Celexa 20 milligrams, and had decreased anxiety and self-harm that endured for 2 years of follow-up. This is a really important study, this one here, a 22-year-old woman with very severe history of intentional self-injury. And I say it's important because all of the people in my trial were safer than this. And we don't have much data about people who are severely self-injuring. And so I thought this was cool that this group in Lübeck came out with this study showing that a series of just 2 initial and then 3 follow-up treatments with IV ketamine initiated a much closer to wellness trajectory for this 22-year-old woman who was doing horrifying kinds of self-injury to herself. And then there are 2 studies, one from the group in Toronto and one from the group in Alabama, that have taken advantage of large samples of people from treatment-resistant depression clinics. And they have analyzed the frequency of BPD diagnosis in the Toronto group case, or, symptoms in the Alabama group. And they found that, as we did, that treatment with ketamine did not result in more adverse events, did not result in dangerous levels of dissociation or ongoing dissociation, and did result in improvement in both mood and BPD symptoms. What our data add are that if there's a placebo control, we're not sure that we're seeing a ketamine specific effect on those outcomes, but we certainly are seeing an effect. So those are the things that I really wanted to present today. And I'm hopeful that we can talk a little bit about these data and thinking about them with respect to other data.
Great, thank you very much indeed, Sarah, that's terrific. So while others are thinking of their questions, perhaps I can kick off and just, well, the first thing was that you said that you had some ideas about why the most intense dissociation was at half dose. Do you want to tell us a bit about that?
Well, right. So, we have reason to think that prior expectations are particularly important in BPD, in mental illness in general, but particularly important in BPD, and that for people who may have had experiences of a little bit of dissociation in the past, getting that initial feeling, people might really sort of be prepared sort of on a neural expectation level to allow it to grow, maybe, I guess I would say, compared to, this may be more related to prior expectations than to a more receptor-based, neurochemical-based experience of dissociation. Although, we don't know that much about dissociation or its instantiation in the brain. And so I think, I guess that I think you might call this an aspect of placebo. I think. I wonder what others think. Did you have thoughts about it, Dr. Machine?
No, I mean, I can quite see what you're saying, that when you think, am I going to get it or aren't I? And then at 20 minutes you think, yeah, I've got it.
This is it.
So that big it up. And, yeah, so I can understand it. Yeah. Okay.
I mean, I think this is a bit like people, who find themselves able to say things that they had really wanted to say when they have a drink or two. Maybe there's like a psychological willingness.
Although that it can last a bit longer, I suppose, when people have ketamine than perhaps. And before we get into other people's questions, I hope I can steal one more, and that is, the most striking thing about this whole study was the number of people that you had to screen in order to get to the final sample. So, and I completely get that you're looking for a sort of really clean sample that where the risks are relatively low and so forth. But obviously the reason why these people, well, commonly they come to some secondary care services because of their risk, and because of their degree of self-harm. And I mean, do you think that it's possible to run studies, RCTs, in people who are really sick like that?
Certainly, yes, certainly. And you pointed out Jerry Sanacora's work. They've done this, and we could do it. The one barrier here is finding the appropriate. So one barrier for our study, and one of the reasons we phone screened so many people, was that we weren't sure what our risk level needed to be, sort of where our risk tolerance needed to be set. And these data have helped us a lot. I think we would feel a lot more comfortable going forward. But, there are certainly studies that pull people right from the emergency room when they come in having self-harmed or reporting suicidality. That's what Jerry's studies do in large part now. And also, but for us, the other thing was having people in treatment. So we required people to have an outside treater. We don't have a collaborating BPD clinic, which makes it a little bit more difficult for us to have people in care to ensure close collaboration with providers. We had some nervous providers. A few times we had someone who enrolled in the study and we called the provider to ensure they were in treatment. And the provider said, talk the patient out of it. For concern. And I think, none of us knew. As a provider, I'm not sure what I would have said. It was hard at the beginning.
By provider, just to be clear about this, you don't mean the provider of the ketamine infusion, you mean the provider.
No, I was the provider of the ketamine infusion, but no, psychiatrists or therapists in the community were nervous. Reasonably so, because we had so little data about what would happen. But no, I think we could do it. I think we just need to work with emergency services and probably set up some more. We would need to have probably some in-house treatment, therapeutic treatment.
And would you next time round, would you use the same placebo, or would you go for a very low dose of ketamine, or would you have them on nothing? Or would you have what would you do next time?
Yeah. I wake up in the middle of the night thinking about this. Maybe saline, maybe a third arm where they get the assessments but not drug. I'm maybe a half dose of ketamine, or maybe one versus repeated doses. Maybe there's a way to sort of think about the value of repeated doses here. I also think that we may want to revisit our rigid weight-based dosing for a range of reasons to do with tolerance. And I think some people got not enough and some people got too much based on weight.
Yeah, did you exclude people with eating disorders by?
We had a minimum acceptable weight. So people had to have a BMI of 16.5, I think. So no one in the study had an active, severe restricting disorder. We saw some people who were having binging.
Okay. All right. Tiago asks, can you make a differential from borderline personality to bipolar? I'm not quite sure I understand the question.
Like, so I would say from a clinical perspective, I would separate borderline from bipolar, partly due to the profound interpersonal symptoms and partly due to the chronology. So I would say that someone who's having more lability during the day in response to triggered upsets is having a more borderline kind of chronology of symptoms, whereas someone who's having more episodic problems that last weeks or months with then euthymic periods is having something more like bipolar disorder with manias. There certainly are data that suggest that ketamine is useful for bipolar depression, which is nice because it, more than some of the traditional antidepressants are helpful for bipolar depression. The other thing I guess I would point out that separates this is that there's a very lovely, maybe one of the nicest drug studies in borderline personality disorder that exists is the British study from about 5 years ago showing that lamotrigine is totally ineffective in any domain, 150 people per group. You rarely see a study this large in BPD, and it's a really useful study.
We're awash with it in the UK, maybe that's why. And everybody who's difficult to treat gets labeled BPD, but that's me being simple.
It's interesting, right? That's not the case. Yeah, that's not the case here.
My question was really about how did you differentiate in this study? You said a lot of symptoms that it really can mess up, or I can in a time frame think that it's borderline, but it looks like, but it's in long time not BPD but bipolar disorder. And how did you differentiate this for inclusion?
Right. So in my experience, people actually make the mistake in the other direction. They think that it's they think it's bipolar when it's actually borderline, I think, but at least in the US, because people are very reluctant to diagnose borderline. But what we did is we did a full SCID interview. Trained clinicians, usually me, sometimes one of my trainees, did a careful assessment of all of general psychopathology. And we spent 4 to 6 hours on these assessments to really get a sense of people's diagnosis. And then for BPD, we used a combination of 2 scales, the Diagnostic Interview for Personality Disorders and the Diagnostic Interview for Borderlines Revised, which has a little bit more of a psychodynamic and interpersonal bent. So it asks about things like counterdependence and that kind of thing. So we required someone to meet criteria on one of those 2 formulations, the one that's more DSM or the one that's more dynamic. And then we did not have anyone in the study who met criteria for bipolar disorder.
And Tiago, do you want to ask your other question about it being a personality trait and therefore not a disease, and so it can't.
That's at least how I learned that it's not a disease, so you cannot treat it with medicines. You need to change the way people are thinking by psychological interventions. Any psychological intervention is okay, but you showed us symptoms and borderline personality symptoms regressing, getting better with placebo or with ketamine, and I got a little confused on how this developed for you.
It's so interesting the way that we're taught about this and the way that thinking has changed over time. I really appreciate this question because I think that some places people are taught that BPD is untreatable. In places that have more access to psychotherapy, and especially more psychoanalytically informed psychotherapies or dialectical behavior therapy, people are taught that BPD is treatable and it's only treatable by psychotherapy. that is the state of the world, I would say. A best read of the evidence says that if you have someone with BPD, you should provide them psychotherapy. I think in the US, because psychotherapy is so difficult to come by and high quality psychotherapy is even more difficult to come by, which is true in a lot of the world, not so much in Western Europe. There's been even more interest in medications. Also, I'll say that probably the evidence that BPD is, or the evidence for the ways in which BPD is held in the brain have lagged behind other disorders that certainly have real world bases like PTSD. Like if you think about PTSD, right, it happened because something happened to you that you've now held in your mind and has become instantiated biologically. And I would say probably BPD has more of a vulnerability biologically that then is exacerbated by early childhood experience. And for some people, it's the profoundness of the early childhood experience or the way that the brain received it. For some people, it's probably the biological vulnerability with a little bit of a nudge from early childhood experience. I certainly wouldn't want to be misunderstood to say that parents cause BPD, but certainly a mismatch between a parent and a child can put someone at a great deal of risk. And, but then that's held in the brain, as I would say all of the mind is, right? And for that reason, I think that we need to better understand the ways that it's held in the brain and the ways that best practice use of all of our available modalities have room to change that. I do think that it's going to be really important for us in terms of thinking about ketamine-based neuroplasticity and other psychedelics, whether there's going to be room, whether BPD really is a disorder of over-rigidity or over-reliance on priors, failure to update with prediction errors. Those kinds of issues could be ones that we could act on by modulating the neural environment and then providing psychotherapy, as has been done by others with ketamine and other psychedelics. I think that's a particularly exciting area, but unfortunately the psychiatric biology work in BPD just lags far behind, partly because we were all trained that this is somewhere out there in the mind, not that stuff that psychiatric neuroscientists think about. I guess I would invite you to say to yourself, yes, I was right, and the mind is in the brain, so what else?
You're citing another other psychedelics for BPD. What other psychedelics are you citing?
People are just starting to think about it. You might have seen there have been a couple of call to action papers now, people thinking about psilocybin and MDMA. I mean, I think a lot of us in the BPD world have read with a great deal of interest the growing literature on PTSD and psychedelic assisted psychotherapy, but also the old psychedelics literature. You know, for example, it looks like in healthy controls, one dose of MDMA alters bias for face perception. Given that this is one of the few well-replicated problems in BPD, I have to get interested, right? So there are things like that that I think require a whole lot more learning for all of us, because we're really at the very beginning of knowing about the biology of BPD. We know a few things about structural difference that don't necessarily hold up across studies, and we know that the amygdala is hyperactive at rest and hyperreactive to almost any stimulus. But really, that's what we know, and that's a discouraging state of affairs.
Yeah. Just some other questions. Did you notice any increase in manic symptoms?
No.
Did Sarah mention why the researchers chose only one treatment? In my experience, treatment effectiveness so much more effective with 6 sessions.
Yeah, thank you. Because we started a long time ago. This study was designed in 2014, and it took us a while to get it done. It was also funded by a small young investigator pilot grant. So this whole study was done on $75,000. And so, that's what we could do. And really because the main goal of this study was an initial assessment of safety. And so the other data we're grateful to have, but they're sort of incidental. Yes, if you are interested in doing a 6-dose placebo-controlled study for ketamine in BPD, please talk to me. I think that would be great. Yes, yes.
I'm just wondering, you talk about PTSD, and so if you kind of allow yourself to treat PTSD, which is a condition which does respond to ketamine well, and kind of leave the concept of personality disorder aside, because PTSD is kind of etiology, so which allows to be addressed with what we have, rather than thinking about tool which we don't have. And that would allow us to help those patients rather than putting a label which we just say we're hopeless.
So I would say a few things about that. Thank you for that question. It's certainly the case that there's a lot of comorbidity between PTSD and BPD, but I would say they're not the same thing. People who have the comorbidity, actually really any severe comorbidity in BPD, sometimes need to be treated for that comorbidity like PTSD or substance use disorder or major depressive disorder before BPD treatment can be effective. But people will not get better without specific treatment for BPD. And really, with the current state of affairs in the world, won't get better really without some psychoeducation about BPD, which starts with diagnosis. So I would encourage you to think about talking to people about the reasons that we should feel hopeful that people with BPD do get better. And that actually there's good data and growing data that even just providing the diagnosis in an empathic way that acknowledges people's experience, saying, you know, I noticed that when you feel really upset, you drive really fast and you get speeding tickets, and you're more likely to go out drinking in a way that's unsafe or with people that are unsafe, or you're having sexual experiences, you just feel like you have to get away from this experience that you're having with your emotions. And when people recognize that, it's such a relief, because otherwise they're walking around with a diagnosis of anxiety and ultra rapid cycling bipolar disorder and treatment-resistant major depressive disorder, and they feel shamed for not getting better from treatments that should help. And so I would encourage you to think about telling people and telling them that it's good news. You actually know what the issue is. And then if you're feeling overwhelmed by helping them find support and treatment, one thing you can do is send them to peer support. There's a lovely organization in New York City called Emotions Matter. You can find them at emotionsmatterbpd.org. And they connect people with BPD with other people with BPD who are on a recovery journey. And this has been a really important resource for many people who have BPD, and it's available to people all over the world. They actually have peer support groups online on Zoom, and people can learn how to find treatment and even just how to feel valued. And so I think that many of us for many years were taught to be reluctant to say you have BPD, as though it would be equivalent to saying, you know, you're a bad person or I don't like you. And I don't think we need to feel that way. Another resource for many of us that's been useful if you don't want to become a focused BPD provider, which many of us don't, is a book called Good Psychiatric Management, which comes from McLean Hospital. This was John Gunderson's work and Paul Links in Canada and others, now being taken forward by Lois Choi. And this is a process of just like having some basic first aid resources for BPD. So you might like that as well.
Great, thank you. It's always good to have extra resources, so that as well as your data, that's great.
Resource plug.
Did you mitigate for blinding retention at the study raters at the study site? So I think can you talk about blinding a bit? And
yeah. So what did we do? So everyone was enrolled and assessed similarly at baseline. We used the Yale Investigative Drug Service, which is a professional clinical pharmacy, to provide, and they provided IV bags that were labeled ketamine or placebo with clear liquid in them. For each infusion, I picked up that bag from the pharmacy and brought it up to the floor. We connected it to an IV pole. There were research-trained nurses there. I sat in all of the infusions. Sometimes I had another staff member sitting in the infusions. And then raters who had not seen the infusion met with the patient either in person or on Zoom after the period of intoxication had concluded at 100 minutes. By that time, no one was visibly high. Then that pair of raters followed the participant, the same two raters followed the participant through the rest of the study. The downside of that is that a relationship was built, and that probably was a part of the intervention. The upside was that a shorthand could be developed and memory could be held for what the symptoms had been last time. Well, it was like this last time. Is it like that now? Is it different? So that's what we did. And and then no one was unblinded. I had my guesses, although I'll say 30% of the time I was wrong about my guess. It was the midazolam was sometimes more, it was more intoxicating than we expected. The ketamine for some people was just sedating. And so I was wrong in both directions, which surprised me. And then we unblinded once we closed recruitment.
Okay, thank you. Yeah, so that's great. I wonder if you know what levels of kappa opioid receptor expression are common among individuals with BPD.
Oh man, the naltrexone study. People have looked at this a little bit, not enough to say much. It's a good question. Some people have tried naltrexone for non-suicidal self-injury, and my last read of the data is that it's not a home run for sure. It's at least mixed. The Yale data don't replicate the Stanford finding in that small group of seven people. I do think this is a really interesting question about what really are the most important receptors for this effect. And I'll say not only do we not know about opiate receptors in BPD much, we also don't know about dopamine receptors. There's some really evocative data to suggest in large patient registry cohorts that maybe stimulants are helpful. We don't really know about the effects of clozapine in BPD. There's so many things. I see what you're getting. I wish I had a better answer to that question. I think it's an intriguing direction. There have been some PET studies from Nate Cola's group in Toronto. I think he's in Toronto, in BPD that might be worth thinking about some more, that I think sort of tack in this direction, BPD and also antisocial PD.
Thank you. You've just answered the next question about stimulants being, the evidence for stimulants. And then the following one is, there's some research psilocybin with CBT corrects a pessimism bias in TRD patients. You mentioned BPD, similar bias for negative emotional interpretation of face. Does ketamine correct the bias for negative emotional interpretation of faces? That's the obvious question, yeah.
So I wish I had a better answer to this, but I'll tell you what I do know. We conducted the reading the mind and the eyes task at each of our time points, and the data are really noisy. We don't see anything. We don't see anything interesting, at least. One thing we're going to do, which is not well substantiated by the factor structure of the task, is to try to look at shift from positive to negative and negative to positive. But really that task is a pretty gross approach to facial expression assessment. We did a little bit of neuroimaging with EEG in this study, and we're still analyzing those data. But we did not look at faces in detail beyond the reading the mind and the eyes. And so I wish that I had the answer to that. I think it's also another good question, and we don't.
Okay, thanks. And there's a question here, or somebody's Ian Stefanuc have very kindly pointed to a paper on MDMA for assisted psychotherapy for borderline personality disorder.
Right. Right. Yeah. Do you want to?
I don't know if that's a trial or not, but
I think it's a call to action. I think this is the paper from the McLean group. Let me see. Maybe I can stop my share. I don't know.
Yeah. Anyway, we're talking about ketamine for that.
Right, but I guess that we're all interested in the idea, this neuroplastic window, and whether MDMA also opens a neuroplastic window. We don't have good data, and it's unclear how to best assess human neuroplasticity in vivo. Sophie Holmes has a paper looking at about 7 people in PET with a variety of depressive disorders, PTSD, BPD, I think bipolar disorder, not BPD, bipolar disorder and depression. And they found a shift in SB2A receptor occupancy that suggests with a suggestive relationship to change in depressive symptoms, but it's a small group of people and it needs to be replicated. But I think that efforts to try to substantiate that neuroplastic window and the neuroplastic window as an opportunity to start psychotherapy are really interesting. And one of my questions is what psychotherapy should we do for BPD, particularly during that window? That I think there's a real opportunity there if it's real to think about those first 3 or 4 days after.
How would you answer that question? What's your current best bet?
I think there might be a cognitive remediation approach with computer-based tasks that could even be done in the home so that it's scalable. Because I think that we need something that's scalable if this is going to go anywhere. And something that requires highly trained psychotherapists with ongoing supervision is not scalable. So I'm quite curious about that idea. Like, could we do like face bias training? Could we do psychoeducation and feedback? And someone here, I'm sure, is thinking that ChatGPT is an answer. I don't know.
I wanted to comment on like what kind of things to work on. If there's social, like the slide that you had about their social problems, would it make sense to have attachment theory kind of as the core? Because when I listen to the criteria for bipolar disorder and I superimpose that on the fact that women can be 4 different people a month, like throughout the month, you have the fluctuations in our hormones, and you look at the criteria and it's like 50% of the time you're okay, 40 or like depressed 40% of the time, and then you're ovulating those 3 days, that's the 5% of hypomania. So is it possible that bipolar, even borderline, is really just people who never learned coping skills in social contexts? So they internalize a lot of these experiences. Like I remember the difference with borderline and bipolar was one of them is out of nowhere and the other one is in response to something that happened. So if you were never taught how to process a situation, you may have these fluctuations, and now we're treating something symptomatically, but we're not getting to the core of like, hey, how do you relate to the people in your life? How do you relate to yourself? So just planting that there.
I mean, absolutely, right? And I think you said, what if it's just? I would say not what if it's just, what if it is? I mean, that would be really important, and that would be enough of a thing to think of as really challenging for people, right? If emotion regulation is another way of talking about that. So I think you could talk about that in an attachment framework and say, maybe the neuroplastic window is a time to accelerate an attachment relationship.
No.
To revisit interpretations from a theory of mind or mentalization perspective. And I think someone in the DBT world would say, yeah, people don't know how to regulate their emotions, and they don't know how to use other people to regulate their emotions. Maybe there's an opportunity for training. And so I think no matter your perspective, an opportunity to change your mind, and then importantly, hold on to the change, is one that I think we would all be interested in. But I think the point you make about attachment is one that might allow us to speak more empathically about people with BPD. This is not something that people are doing to us to be terrible or manipulative. This is something that you come by honestly based on your early life experience, and then go on to try to make your way in the world with a lot of confusing data. So I think, and then I do want to really come back to your point, Julia, about the menstrual cycle, which is that few, if any, of the studies in this field have timed infusions with menstrual cycle or assessed or thought about menstrual cycle. And I think there's growing data that this is critically important when we're measuring people who are cycling. So I think for any participants who are cycling in our studies, we should be measuring and timing treatment. And so one person working in this area is Tori Eisen. I'm sorry, I don't know her last name very well, but she's at the University of Illinois, Chicago, doing really lovely work about menstrual cycle in clinical trials. And I would encourage all of us to take that seriously. So thank you for that point.
That's a good point to make. Thank you. Yeah. Would you offer borderline personality disorder patients maintenance ketamine and ECT? We found some BPD patients want to continue frequent ECT despite there not being improvement in their symptoms. They get attached to the treatments. So dependence.
Yeah. So what can you do? People come in and right. And I think that this is a question I have about our results and the results of any intensive treatment, right? So you're out there, no one wants to hear it about your symptoms. No one wants to talk to you. People keep saying it's your fault. And then someone offers you to come in and be put onto a bed with fresh sheets with a nurse checking on you and giving you juice every 15 minutes. Like, I mean, of course people get better, right? And so I think our question isn't, is there a placebo effect here? Our question is, does ketamine offer anything above and beyond the placebo effect? And if an intensive, I mean, honestly, if the treatment for BPD is well-trained college graduates, like in my study, right? These were 22-year-olds that sat with the patients for, 2 hours every week. Or if it's nursing staff and juice, we've learned a lot, right? And also how sad it is that we haven't offered that before, right? I think we should be concerned not so much about how to maintain, although that is an issue because we don't want to be providing people unnecessary drug, but also how to stop. Because I think that the time when we cut off treatment is a very high risk one. And this is not an answer that we have a lot of data about. We are in touch with most of the people in our study and we haven't heard of any negative outcomes. How
many of them went on to have the clinical treatment? You referred to one patient.
That I know of, about 4 of the 10. One of them was in a residential program that didn't want to provide it to her, and she hijacked the system and got to the emergency department and demanded it and then got it. One of them, I have 2 who have gotten 6 months or a year of ketamine from the Yale service with Robert Ostroff and have done really well. And especially I work with Rachel Katz over there, and she's done really nicely with those patients. And then let's see, some of them, the other ones who got, one of them went to another city on the East Coast that he lived closer to and got it there. It seemed to organize people enough that they could sort of work out seeking it out, which was often sort of the barrier. The reason somebody got into the study was that they wanted a safe place to try it. And they weren't really sure. And it's hard to sort of tell, like, it's hard to parse the available options for ketamine access because they're quite variable and some of them are pretty gimmicky. Drug-seeking behavior. We did not see any evidence of people having problems with substances in our study. We did not see anybody seek out, that we're aware of, ketamine or any other illicit drugs in the month of follow-up. Nobody reported cravings to us, although we did not specifically focus in detail in this area. Demanding at the ER, right? In the last week of study, she wanted to negotiate getting clinical ketamine from her program, and the program staff said, no, we don't think it helped you. Although interestingly, by our ratings, it did. And so she reported intensive suicidality. I think it was more of an interpersonal conflict with the staff. And then she figured out how to sort of do it, I'd say, yeah. But I see your point, yeah. Let's see. Are there other things in the chat that I missed?
So yeah, I mean, that's anyone who's got put your hand up if you've got anything you want to ask.
I may have a question, if you don't mind. Sarah, terrific talk and terrific discussion, I would say, afterwards. I was wondering, in the moment you consented them, and you set up a bit maybe the expectation, or you explained to them what to expect during the course of the infusion, was that in any way different from what you would like normally do with a depressed patient, for example? And if I may also ask you another question, in this like sort of non-separation between the active placebo and the ketamine group, because your team was meeting with them so often, do you think it was like mostly because it increased the placebo response, or was like really more failure of the ketamine to really differentiate from the placebo?
I really wish I knew the answer to that question. We don't know. It could be that both groups benefited from it. It could be that we're at a ceiling effect of improvement and we brought the midazolam group up to the ketamine group by meeting with them. We won't know until there's more work in this area, I don't think. I will say the first question, the first question?
When you consented them, or when you prepared them to have the infusion, did you, how do you present the infusion to them, or the experience they may have during the infusion? Was that different from what you would say to them?
So, right, I was taught to evoke placebo effect when I prescribe. So I probably prescribe differently from some people, but the way I always prescribe to anyone is with a great deal of expressed uncertainty and hopefulness. So I would say to you, Sarah, we've been talking for a while, and I can really understand that it's important to you that you get better sleep at night, and also that you don't experience weight gain from treatment. So I considered all of the antidepressants that are available to me. And, I was thinking initially about one that people often prescribe for sleep, mirtazapine. But, unfortunately, it is associated with some weight gain at the doses that are most helpful for sleep. And honestly, I know that you've tried 3 medications so far. So, I really think at this point we might want to consider a new option, and that's ketamine. Now, there are some downsides to it, which is that in our setting, you would have to get an IV, and it's only given at the hospital. But, it's helped a lot of people. And, when I say a lot, I mean about 2 out of 3. So you and I both know that if I told you that a medication was going to solve this problem, that I would be telling you things that weren't true. I can't be sure. But given everything that's gone on and what we know together about your situation, I really think this is where I would go next. What do you think about that?
But so you wouldn't highlight the downside of the dissociation, or maybe a potentially
for BPD in particular, right?
Population.
Yeah, so I probably would say, right. So then the next steps would be, there are a few other things. It could make you feel pretty strange while you're getting it, but I would expect that to fully resolve. Also, when you feel, I would tell people that when they feel this much better, there's a risk that when you stop it, it might be really hard. And I might tell them that we would need to be working the whole time that they were getting the ketamine on building more of a social network, because it could be very lonely. I would name it right up front. It could be very lonely if you're going to the clinic all the time and your life becomes busy with clinical care and you feel like, really cared for there. And I would name it. I would say, you and I both know that you're very sensitive to social interactions, and it could really hurt to spend a lot of time there. And then I would just put it right out there, and I would make that the focus of the work. Probably is the way I would approach it.
Can I ask a last question? If there's anything that you can say about the deliberate self-harming behavior, the non-suicidal self-harm, and how that was impacted at all?
Yeah, we don't have formal scales about it. We haven't looked at the data, but we do have very clear and long histories of people's trajectories of self-harm over the lifetime leading up to the study. We did careful interviews about that. We do have, I suppose, the one question on the Columbia Suicide Scale does ask one question about whether you've done any self-injury on the behavior part at the top. I don't recall that anyone endorsed it after ketamine, but we didn't have a lot of frequent self-harmers, coming into the study. Not because we excluded them, actually, just we didn't. I happen to have them. We did have people who'd done it in the past, but we could look back. We have not analyzed that outcome in particular, and it is a good question.
We're up against the half hour.
Right.
Thank you very much indeed. It's always nice to get, it's particularly nice actually to sort of get a sense of people's clinical, how you talk to patients. I always think that's great, and you know, tips like that. It's very interesting. Thank you so much. Very great data, very interesting study, lots of good questions, and we really appreciate you taking the time out to talk to us. So thank you so much, Sarah.
Yeah, I hope to come back.
Yeah, let's come back with the big study. Yeah, that would be great. Okay.